I think it's essential to build on the many great examples that we already know of about how clinicians from different backgrounds are coming together to think afresh about how to use the resources that they have to provide the best possible care for patients. There are some great examples here of how people are already doing that, building on really strong clinical leadership, building on a really systematic approach to using information, and building on engagement with patients and the public.
We've managed to get some very significant initiatives off the ground, or the PBC have, and certainly the PBC clusters have been excellent in this regard right around the county. I think the issue though is really whether or not, given where we are in the NHS, in terms of particularly moving patients out of hospital, improving the standard of care for them, and obviously at a better economic value, it's whether or not PBC has actually fulfilled its full potential. And I think that's really where we are. Certainly our PBC clusters have been excellent, but I think that's probably the unanswered question. Well, I think the main thing is what's been underpinning this is really to do with having buy-in and a joint approach between ourselves and PBC. So we're just about to roll out a very, very large musculoskeletal assessment process in order to, A, improve the standard of care to patients. And that's, for me as a doctor, irrespective of the money, that's one of the most important things. So it's actually improve the standard of care for patients and also deliver a lot of the savings. And essentially, as I say, it's to move what previously was secondary care activity into primary care.
Key relationships. First and foremost, we've got to keep in touch with our grassroots. Grassroots are what is what will make GP-led commissioning different. So we've got to keep in touch with the GP surgeries. I know that might seem like a no-brainer, but it would be very easy for a GP-led organisation to set itself up and become distant from its grassroots. And I think we need to make sure that it's ingrained in our way of working, that we link very much with them. And in fact, we'd very much like a democratic way of doing that, so that we're accountable to our GP colleagues and they can hold us to task in terms of how well we're doing as a GP-led group.
We have a huge amount of data in the NHS, some of it useful, some of it not, but the connection with the people is the really important bit in actually changing someone's life. When we've introduced things like pulmonary rehabilitation, the feedback we've had from people has it's transformed their lives. That's not about data, that's about commissioning for the people and commissioning for the GP's patients. We've been fortunate to, first of all, live within our means and live within our budget over the past 4 years. We've been able to work collaboratively with our local hospital to improve standards there. A couple of years ago, they rated us weak for clinical quality. The year after, we were working with them to get them up to good. They would have achieved excellent this year had they not changed the standards that were rated against. That's critical. We place a lot of emphasis on health inequalities, and we've spent a lot of time trying to improve the health of those with worse health outcomes first of all. And as a result, we've put in place a health and wellbeing team that goes out and targets those at risk of cardiovascular disease. We've worked in partnership with the local fire brigade to borrow a bus so we can take this out to our population, and that's been really well received. And actually we've picked up people with quite serious medical conditions that would have gone unnoticed had we not put that in place. The transition between the PCT and the GP consortia of the future can be quite simple, in my opinion, and myself and my other colleagues from practice-based commissioning groups in our county have recently joined the executive team of the PCT, and collectively we review performance, and we're trying to transfer many of the skills from a PCT to GP consortia, as well as bringing our skills and our way of doing things to a PCT. So we hope to minimise the impact and prevent complete inertia for a year or two while the handover happens.
Okay, as we've started to move towards GP commissioning consortia, what we've seen locally is many more practices start to get very, very interested in the very detail of the data that their practice is receiving, and many practices now across LLR are engaging in practice level audits around, for example, 0-day length of stay emergency admissions, or their top 5 emergency admission HRGs, or A&E admissions that were in hours, and they're beginning now to get a forensic grip on what is happening to their patients and when is it happening to their patients. So the opportunities that data provides are, how do I intervene in those systems in order to meet the productivity challenge that the NHS is going to face over coming years? And by providing local data sources alongside national data sources, you know, particularly from the emergency care issue, you know, a live feed of which patients are in a hospital bed at the moment is very critical in individual practices, understanding how spend is taking place today against their budget.
I think the biggest challenge is that we have a provider-led NHS, and a provider that are based around around trust status, which makes them be a commercial organisation, and so their priority is always to make sure that they're financially viable. And neither PCTs nor practice-based commissioning has ever had the leverage to change that. And I think that we have an opportunity to bring some pressure on our providers to rethink the way that they are working. I think every clinician along the patient's pathway should understand and be responsible for the financial consequences of their decision, whether that be the GP or a nurse or a consultant or a radiologist. They should all own that pathway. And I think we need to have a major culture change within the health service, where we have true partnerships with primary and secondary care rather than lip service, and where the local trusts and providers have a responsibility to make sure that limited resources are properly used for the whole of the healthcare community. But that's the biggest challenge, to change that culture and have sufficient leverage to make them want to change.
We've got a really good, a commissioning group put together already, and then we've also got tools that have been implemented by that group. We have a magic tool that we can actually look into and start looking at referrals, start looking at the cost of referrals, looking at A&E attendances, things like that, things that we're going to have to look at in the future. And we have got a good commissioning team that help us with that at the moment.
Absolutely. I think there's a big challenge to avoid reinventing PCTs. And I think part of the issue there is about hanging on to not just the individuals who have expertise and knowledge, some of which you could write down, but some of which is purely contained in their heads, but also hanging on to some of the approaches. So for instance, in Knowsley we have an integrated commissioning approach that sticks the out-of-hospital commissioner, the hospital commissioner, the independent contractor commissioner, the 3 PBC leads and the urgent and unplanned care commissioner together in one room on a regular basis, where we are all able then to interplay about how each of our individual commissioning briefs interact with other people, and that gives us very, very good, strong way of working. We also have the children's commissioner in there from as and when required. We need to keep that going with GP consortia, because if we don't, then we run a risk of fragmenting health and social care commissioning, and if that happens, then that will really, really have a bad impact on our system.
In practice-based commissioning, it was well recognised that there was a broad church approach to redesigning services, which included community staff, allied healthcare professionals, social care professionals. The term GP commissioning was delivered to focus the efforts of the referrer, but never meant to exclude other healthcare professionals. So we need to get that message loud and clear, because we know in the clinical community that service redesign and the delivery of care, particularly from the general practice space, is not something that the general practitioner and the practice nurse with an administrative team can do alone. So there are programmes that are starting nationally to make sure that other healthcare professionals are well stitched into the whole programme of GP commissioning.
It has been identified that PCTs currently carry out something in the order of 300 different functions. Now, some of these will pass to GP consortia, some will pass to the National Commissioning Board, and some will pass to the Health and Wellbeing Boards. Those functions that do pass to GPs need to be delivered in the main by their commissioning support offer. We mustn't turn GPs into commissioning managers. The added value we need from clinicians is the development of care pathways and the sitting down with our colleagues in the acute sector to find the different ways of doing things and implementing it.
Firstly, one of the successes of practice-based commissioning is clinical engagement. We were able to reach out to a number of clinicians, not only in primary care but also in secondary care. That just enabled us to begin to address the whole of the audience. So that was quite important. The second thing is that engagement between clinicians and management. And that was real. And there was a number of projects that we did which actually started with the relationship between clinicians in primary and secondary care. And then for us to take that further, we absolutely needed management who came in to aid that process. So it was pretty much clinician-led, but management supported and backed.
I think practice-based commissioning was fundamentally about improving primary care and getting consistency across general practices, but then also extending the range of services which are available out in primary care. So we had a number of projects. I think Jude is right. It was essential to have those projects designed by clinicians, but then with managers putting them into place. And I think it's learning from that process, the real clinical engagement, that we can make GP commissioning successful too. Well, we've managed to get many things off the ground over the last 4 years through practice-based commissioning, which have really changed and improved services. The key one, perhaps, is the A&E diversion scheme, where a number of GPs looked at the number of people attending A&E with primary care problems during the day and at night time. And what we worked on was that every general practice in the city, if contacted by the A&E department, would be able to offer a patient an appointment either that day or the next day. So for the A&E clinicians, we work with them on identifying, well, what conditions do people turn up with that could be easily dealt with by their general practice. So it was absolutely a partnership between the GPs and the clinicians in the A&E department. And from that, what happened was we introduced EMIS, which is the GP clinical system, into the A&E department. So the A&E clinicians, both on the front desk and behind in the more complex areas of A&E, can now access GP clinical records, so they can give a much better care to the patients because they understand fully what's going on with them. Our current position is that 250 patients a month are diverted from the minors A&E department at the Royal back to their general practice, which is 5% of the activity, so it really is starting to make a difference.